Good evening, members, and welcome to our IDS webinar. It's the first time I've said that.
Really?
Yes,
How's it
first time.
sound?
Sounds kind of awkward. But
Okay.
but for those of you who are confused, yes, this is the AAIP webinar. We have changed our names for those of you who don't know. We are getting used to it ourselves. We are IDS. We are the Institute for Dental Specialists. We are powered by the AAIP. So we are still the same people. So stay online.
That's
Don't
me,
go anywhere.
Probably can't understand either of us. We both have colds.
Yes. So when I cough, he'll take over, and vice versa. We have a plan here. So it's getting cold in Florida. It's like it got down to 40. 40?
Tell the people in Chicago that, yes.
We had our heater on. All right, guys. So we have a few announcements to make. First, we are going to be on the west coast of the United States in January. We are going to be in San Diego on January the 18th in the evening, speaking with and to. This is the West. I'm sorry. Was it the San Diego Society of Perio? And then we are going to be in Arizona on the 20th in the morning. So if you're near the area, let us know. We'd love to see you out there.
Actually, we'll be in Phoenix, Arizona.
Yes.
So that's the Arizona Society of Paradise.
Yes. So yes, come out and see us. We're going to be at a few more locations during this year. We are planning at least 6 or 7 or so more. Yeah. So look for us in your area. We'd love to see you. This is 2018. We're packing in to be, as we always say, our best year ever. So stay tuned for our announcements, our changes, all of our exciting stuff, because we are getting ready for it. We're getting our suitcases ready. We're going on the road for 2018. And also, just because the holidays are coming, just take note, the next webinar we're going to be doing is on January 10th, and that one's going to be increasing your new patients by 10% with no marketing expense. So stay tuned for that one as well.
Good. So let's talk a little bit about, embellish a little bit upon what we talked about last week, and that is the 12 attributes. But I'm not going to talk about the 12 attributes specifically. I'm only going to talk about one particular one, and that is to separate yourself, differentiate yourself during your marketing, not during your marketing, during your examination. So, and we haven't covered this, so we're going to talk about a little bit about clinical things today. Some things may be controversial, and so what? So we'll talk about
What's
that.
What's new?
Yeah. What don't I say that's not controversial? So let's see if we can get this. Okay. So there are some things that we can do to improve the delivery of information that patients have. Many of you are seeing a lot of dental implant patients. You're seeing patients who have high level of caries, particularly those patients who are coming in off the street. And sometimes people want to know why. You know, and even we want to know why. And so we do a detailed history, and we talk specifically about sugar and exposures to sugar, as you would expect. We'd also look at the 400 or 500 medications that cause xerostomia. But still, that's more with regard to history. One thing that's really important is what's the pH of the mouth, and we can tell the pH of the mouth very easily by using one of the pH papers. There's a number of different pH papers. You can go on Amazon and you can see the different ones. We know that enamel will demineralize at pH of 5.5. A lot of people are sitting at 5.5. They really are. In fact, this particular paper only goes down to 5.5. I would look for a paper that goes down to 4.5. And it's like a litmus paper, you know, like a graduated scale. So you can have the patient put in his mouth, or you can have the patient spit in a cup. You can dip this strip in the saliva, and you'll have an immediate color readout, which you can show the patient. You can say, this is why your teeth are decaying. Now, for some patients, that may be the reason why you should extract the teeth and put in dental implants, because the patient is prone to decay. But now you've given the patient a why. Why is my pH so low? We can get into dietary history. You can talk about that. You can talk about sugar. By the way, meat is quite acidic as well. And if the patient is willing to change his or her habits by using things such as caries-free or frequent baking soda rinses. Have the patient take this pH paper home, and the patient can monitor him or herself every hour and see when the pH dips down below 7, which of course is neutral pH. And they can then decide how often they want to do the caries-free or how often they want to do the baking soda rinses in order to be able to keep the pH up above 7. You now have a patient who you can work with, and the patient now has a measure that he or she can apply to get the pH back up to normal levels. And the patient might say, I can't do that. I don't want to do that. Well, then maybe an implant is a better idea rather than doing the root canal, the Boston corner crown. So it gives the patient a measure, and besides that, nobody does it. So you can be the one to do it. And now you become more of a diagnostician. Nobody's done that before. So this is something, I use pH paper every single day. I don't use it on every patient, but I do use it on patients who are caries prone in order to be able to allow them to see what in fact is the reason for their caries proneness, if you will. Another thing we've talked about is imaging, but we've never really done a full imaging program here. I'm going to do that for you today. We did this at the AAP in Boston, and we're doing this on our roadshow as well. So if we're doing it on the roadshow, you should be getting it too. So all of you know we use the company Snap, capitals S-N-A-P. They're on the west coast of Florida, and we found this to be a tremendous imaging program. And after I show you this, Daniel will tell you a little story about this patient, or maybe I'll tell the story.
I could try.
All right, good. So let's look at imaging. So this is Amy. And you can see this is fast motion. You can see all we do, you can see how I'm tracing the inner portion of the lip. And very simply used. So I'm just doing this with the mouse. And then it says next, so I push next, and now we get a selection of smiles to use. You can change the brightness, you can change the color, you can change the curve of the arch. A lot of things you can do very, very quickly. And select the teeth that you want, move them in the correct position. Notice she's looking a little off to the side. I wouldn't have taken the picture exactly this way. You want the patient to be full face, but even with the patient looking a little bit off to the side, you're still okay. And now you see the before and after. Now here's the story on this is an interesting story. You all know that we encourage you to take full face photographs and make sure they're on a big 40-inch screen in front of them so the patient can see this. Well, this is an enhancement of that. Not only are they critiquing their smile, but they're seeing what they could look like in a new smile. Well, on the day that we saw Amy, for some reason the computer wasn't working, or the Snap program wasn't working, or something wasn't working.
Yeah, the program wasn't working, so I didn't do this with her. And I probably would have been apprehensive about even doing it. Anyways, we had just gotten this program not too long before Amy had come in, but she was an extremely easy patient. She was very funny. She was very comfortable. She was very likable, and she came in and just said, you know, I'm just going through a divorce, and I want an amazing smile. And she was really open to what we wanted to do, and so she was really easy in and out, and scheduled to have upper and lower extractions, implants, and fixed and prosthetics. And she had called back at the end of that day to cancel her appointment with me for the next day, which was for her to come back for her pre-op and get ready for her surgery. She'd already scheduled her surgery, and I had asked her to come on. It's still go on ahead and come on in, so I could, you know, finalize her paperwork and give her her stuff. Because I wanted to talk to her, because I knew how much she wanted to have this smile. And so when she had come in, asked her what happened, and she said she doesn't want her teeth taken out. She doesn't want to get a denture. When she was married, she wanted a beautiful smile, but her husband at the time said, get a denture, just get a denture. And she didn't want a denture because she knew what a denture would do to her, so she never fixed her smile. and he had left her for someone who had a beautiful smile. And so she says, I'm not doing what it is that he wanted me to do. I want to have all my teeth. I want to have my teeth, and I want to have a beautiful smile. So I then asked her to take this picture with me. I took the picture and I did this, and I explained to her implants and the prosthetic, and the palate will be free and it's permanent, doesn't come out, so on and so on, and gave her this picture, and she just said, this is it. This is what I want. This is I'm not canceling. I want to have this. And she turned all the way around, and she held on to that picture tight, and she wouldn't let it go. She took it with her, and that was what she wanted. She wanted the keys to the car that she dreamed about her entire life, and she was just amazed. It sold the case. This sold the case.
Now, the end of the story is this. She met her high school sweetheart. They communicated by Facebook. Somehow he found her, and they're back together again. This is, when we tell our stories, we're going to talk about the implant lecture in the first quarter of next year. I think it's in March. It's the emotion. It's these emotional stories that connect with the potential patients that show up at your implant lectures. And to be able to tell a story like this, smile, husband said, nope, I'm not going to spend the money on you. Pull out your teeth, get a denture. Husband leaves for another woman. She finds high school sweetheart. High school sweetheart says, you have the same smile that you had when I knew you when you were in high school. They're back together again. Those are the stories that connect. We talk about emotion a lot. Those are the stories that connect. And you all know what a patient needs to spend in order to be able to do upper and lower prostheses that are implant supported. That's how you can convert these patients. So don't underestimate the power of this photograph, not just what she does look like, but what she could look like. Another one we use, there are a number of different programs like this. I happen to like the Anatomage program, which I believe was the first one like this. Now, I'm going to show you in a minute how you use Anatomage for dental implants, but I'm showing you this particular view because it makes this much of a difference. A number of you are doing mucogingival procedures, and whether you're doing pinhole grafts, whether you're doing subepithelial connective tissue grafts, or bone grafts in some cases, because you're doing a PAOO procedure, or Wilcke-Donnix procedure, or POPA procedure, as Colin Richmond calls it, patients want to know why. And you can show them a CT scan, and we do CT scans on these patients because the patients now have, and we now have, a three-dimensional view of what the alveolar bone support is like. And when a patient can now see the scalp shape of the roots and see how the interproximal bone is actually narrower than the bone over the facial and how thin the bone is over the facial portion of the roots, they get another why. They have an understanding. And then when you talk about why you need to correct that area, whether it's with bone or whether you're doing another procedure, you're increasing the blood supply to the area, because if not, this tissue is so thin and the bone is so thin that it's going to continue to recede. This makes a difference. And again, we're talking about differences that the patients haven't seen before. There's a difference between seeing this and having a patient run his finger over the vestibule in order to be able to feel the prominence of the roots. And I'm not saying that isn't a good way of doing it, but this is a little bit more of a high tech, and frankly, it's something that's expected. If they go into their physician's office, they see images like this all the time. And you can do the same thing, whether you own a CT scan or not. You have them take a CT scan. You have the Anatomage software. You can run this in the software, and the patient gets a better appreciation. And again, this will improve, or at least in my opinion, it will improve your acceptance rate because the patient is now seeing something that's a little bit different from what he or she has seen before. But let's look at this edentulous space, and I mean, we can argue whether this edentulous space should even be filled with anything, and I'll certainly take your argument and say, all right, the space is narrow, but I just want to show, using the same radiograph, how we can use this software in order to be able to explain things to the patient. So now this is what's called the teeth view in Anatomage, and You can see where the number 22 site is. It's narrow, teeth have drifted. I understand all of that. But let's take a look at it in a different view. Okay, so now we put an implant in place. And notice on the left screen, can you see my pointer right here? You can see where the bone is, and you can see the trajectory of the implant vis-a-vis the upper canine tooth that it's going to ultimately occlude with. So the patient can see, number one, that the implant can fit in this space, at least from a facial lingual direction. But now we take a look, and finally we are able to put a crown in that place, and the patient has an appreciation how narrow the crown is, or why you may have to disc the distal tooth number 23 and the mesial tooth number 1 in order to be able to get this crown to look a little bit better. In addition, because this bone is so thin, the patient has an appreciation now as to why a surgical guide will be of benefit, so that we're actually splitting the uprights, splitting the cortical bone and putting a narrow implant in order to be able to get that in place. Plus, we can put the crown on to show how the crown is going to occlude with the lingual aspect of tooth number 11. Patient sees now some intricacy, and they see some diagnostic expertise that they may not have seen in the other office that might have said, you need an implant. So we use the Anatomy software for everything, whether we're doing a full arch case or whether we're doing a single implant, if only for demonstration purposes. And of course, you can also use it to create surgical guides if that's a particular technique that you use. Also can see the reason for bone grafting, or do this little bit of alveo here in order to be able to get rid of this lip of bone. Lots of things you can explain by using this software to explain it. My favorite book right now is Beat the Heart Attack Gene. Beat the Heart Attack Gene is done by Dr. Bradley Bale. Dr. Bradley Bale specializes in treating patients who have had first heart attacks. He's in Spokane, Washington, and periodontist that some of you know. And the only reason I'm giving her name is because her name is used prominently in this book as a patient. Laura Lee Nygaard actually saw Dr. Bradley Bale after she suffered a stroke at the age of 37. Let me play a little bit of this for you, and then we'll talk about it on the back end.
There is now a sophisticated diagnostic tool to detect gum disease. Two companies, Oral DNA and Hain Diagnostics, offer salivary DNA tests that identify the concentration of bacteria in the mouth that are known to be associated with cardiovascular risk. These tests use high-tech DNA analysis, a more reliable technology than traditional culturing techniques. Studies are now demonstrating that it's the burden of these germs that drive CV risk, as opposed to simply making a clinical diagnosis of periodontal disease through a traditional dental exam. The advances in testing are improving diagnosis of PD. Do you need an oral disease detective? Wesley Robinson used to be one of our most baffling cases. At each follow-up visit, despite aggressive treatment with lifestyle changes and medications, the 6'1" Texan, whom we'd nicknamed Superman because of his brawny build and six-pack abs, still had the cardiovascular equivalent of kryptonite in his arteries, inflamed plaque. And no matter what we tried, his disease kept getting worse. It looked as if Wesley, 44, might be headed for the same fate as his father, who was disabled by a stroke at age 55, and then suffered a heart attack at 58, or his grandfather, who had died from a heart attack at 60. At one point, as you heard in Chapter 7, we thought we'd solved the mystery. When we summoned Superman and his worried wife Kelly to our office to discuss his alarming lab results, he admitted that he'd quit taking one of the medications we'd prescribed, niacin, because of a minor side effect. After we pointed out that Wesley could live with a slight medication side effect, but might not survive a heart attack or stroke, Kelly fixed Superman with a gimlet gaze and announced, he'll take the niacin. Wesley did resume treatment and achieved excellent cholesterol levels. At first, his inflamed arteries appeared to cool down, but then his inflammatory marker started to rise again, despite his compliance with niacin treatment. The continuing inflammation indicated that he was still on the fast track to a heart attack or stroke. Knowing that Superman had a family history of severe periodontal disease, in fact his father had lost all his teeth at age 35, we always suspected that PD might play a role in Wesley's disease. When he was queried about this possibility, however, we were always reassured that his dental checkups were fine. In addition, at the time, we were not using the two tests discussed in this chapter, the IL-1 genotype test and MyPeriopath. When we later became aware of the availability of these tests, we incorporated them into the Bale-Dunine method. Because several of Wesley's inflammatory markers remained elevated, we recommended that he undergo these oral health evaluations. Superman's wife, Kelly, a dentist, questioned the need for testing. I was skeptical because although there were a few areas in his mouth that could be better, there was nothing to make me think that he had active periodontal disease, says Kelly. Overall, his gums looked healthy, so I was shocked when the MyPeriopath test came back positive for periodontal disease, showing that my husband had very high levels of 3 types of bacteria. Superman also turned out to be a carrier of the IL-1 gene, explaining why he was so prone to both inflammation and oral infections. His MyPeriopath results included recommendations from the diagnostics lab about which antibiotics might be helpful, as well as his levels of 11 pathogens, disease-causing bacteria, that cause gum disease and boost risk for tooth loss. Kelly decided to try treating her husband with antibacterial mouthwashes, improved oral care, including twice-a-day brushing and flossing, and thorough professional dental cleanings every 3 months. We were amazed at how quickly his inflammatory markers fell once the bacterial load in his mouth was under control, says Kelly, who was extremely relieved when a CIMT scan confirmed that her husband was no longer on the fast track to a heart attack or stroke. I was very skeptical about this testing since his mouth looked pretty healthy, but the results have made me a believer. Should you get salivary DNA testing to check for dangerous oral bacteria? We recommend this screening test if you have persistently high inflammatory markers, a history of clinically diagnosed PD, or have suffered a cardiovascular event. If none of these factors apply, we recommend that you get regular dental care according to the schedule advised by your dental provider. This should include screening for PD, which involves taking painless measurements of pocket depths with a periodontal probe. If you have any pockets in your gums measuring 3 mm or greater, then you have periodontal disease and need the treatments discussed in Chapter 14 to protect both your oral and cardiovascular health.
Okay, so how do we use this? Number one, we have this book in our office. And now we have a few things that we can do. Number one, we're not just talking about periodontal disease by itself. But now we have a book, a reference book that allows the patient to see the health risks that are involved with periodontitis. Don't forget this is written by a physician. By the way, you're obviously hearing the audible rendition of this, and I would encourage you to listen to the book or read the book yourself, because periodontal disease is one of the 30 markers of inflammation that this doctor uses in order to determine how to help a patient who has a heart attack risk or a stroke risk. And by the way, most of the patients that he sees have already had first heart attacks or have had strokes. And his whole goal is to prevent a second heart attack or a second stroke from occurring. And he's very, very successful. In fact, one of the guarantees he gives is, or the guarantee that he gives, we talk about dental implant warranty. His warranty is this: follow my program. And if you get a heart attack or a stroke, I'll refund all of the money you spent on it. And I believe about 10 years of practice, he's had to give one refund. So understand that this could, first of all, this book could be quite valuable for you. And you'll look in your area and see if there are physicians who are practicing the Bale-Dunine method. You could actually interact with these physicians. Patient discovered me, and I discovered this whole Bale-Dunine method because a patient who is about 60 miles away from me was given this test by her physician who follows the Bale-Dunine method. And she flunked that test. She had Porphyromonas gingivalis and Treponema denticola, I believe. But he couldn't find a periodontist in his area who believed in the test. Now, we've been using the oral DNA test for probably 5 years. It's a great test. It's fantastic. The patient then looked me up, found my website, saw I do the oral DNA test, and now the patient drives 60 miles to me for me to help her control her periodontal disease. Then I meet the physician, and now the two of us are buddies. As a matter of fact, I'm going to see the physician myself. In fact, I'm seeing the physician myself because of the thoroughness and the depth to which he looks at inflammatory markers for cardiovascular disease. So this can produce a tremendous relationship. But let's look at it differently. Patient comes into you, has already had root planing done by the general dentist, and you've seen these patients before. Okay, so now you're going to do root planing too. Or you're trying to come up with some Mickey Mouse way to explain around why it didn't work in the general dentist's office and why it's going to work in yours. And you know how you skate and how you say certain things and come up with the right terms, and sometimes it works, but a lot of times it doesn't. Well, now you can have a patient spit in a cup, talk about the risk factors involved. Maybe show them a couple pages in this book. Send the saliva out to my periopath, and now you can get these bacterial markers, or are there genetic risk markers you can also find as well. If the patient wants to spend a little bit more money, you can look at a single marker, which is related not just to periodontitis, but you can see what's written here. Or you can get a series of markers, which shows the patient overall cardiovascular risk and other risks of inflammation, which can be quite helpful. And now you've raised the bar in the patient's eyes. You're not just using a periodontal probe and saying you've got a 7. Now you've got markers and you've got risk factors and you've got charts patients can understand, so that they can see that in fact you have maybe a stronger knowledge base that can help them in more than just helping their teeth. My periopath, I believe, is a significant adjunct to our practice. We probably use it in anywhere between 50 and 75% of our periodontitis patients that come into our office. And the recommendations they do have, just as you would see with the culture, they do make recommendations with regard to antibiotic use if you find it to be appropriate. And I would encourage you to use the MyPeriopath test. You should use it before and use it after treatment to make sure that these periodontal pathogens are actually well under control. And you introduce that as part of your financial arrangements. You've got Porphyromonas gingivalis. We want to make sure that's gone because that can be a significant risk later on. And so you complete your root planing, you reprobe, you complete your periodontal therapy, and just to check to make sure that it's under control, you do the test once again.
And this test does make a huge difference in case acceptance, because when they understand that periodontal disease is a whole body issue, they change their tune on it, because prior to us having a lot of this information and diagnosis on this, it was, to me, the hardest case to sell, because a patient doesn't quite understand, because they don't have pain, they don't feel different, they don't feel like they have disease, they don't see anything. So we're trying to convince them that they have this disease that they can't see or feel, and many of them are just like, oh, I'll just go home and brush better, because they don't understand it. So this really kind of brings some reality that it's a whole body issue, not just your mouth, it's your whole body. And they listen, and those graphs, those numbers, that testing does make them listen a little bit better to what's going on.
Next thing is shim stock. I use shim stock on many of my patients. Teeth should occlude. And so when we're looking at a patient, and the patient might want to know, why are these restorations breaking down, or what is going on here? And we can look at it from a TMJ perspective as well. How easy, how many teeth are meeting, and how good is the occlusion? We can all buy a T-scan, and I have a T-scan here, but it's in the closet. I don't use it. But shim stock, I can just take a very, very thin piece of cellophane, and we can see which teeth are meeting and which teeth aren't. Essentially, what I'll do is we're just going to go through this. I'm going to place this thin piece of paper between each of your teeth, just close down, and I'll say plus or minus. If it's plus, we know the teeth are meeting, and if it's minus, the teeth aren't. You'll be surprised at the discrepancies that you'll see, and particularly when you're doing your implant planning or even your occlusal planning for the general dentist. where you might find that some teeth are out of occlusion, again, you're now giving the patient a reason to have dentistry done. Teeth are made to meet. If they don't meet, then there's something wrong. And so we'll say number two plus, number 3 plus, number 4 minus, number 5 minus, number 6 minus, number 7 plus, number 8 plus. Just go all the way through, and the patient knows in advance that plus is good and minus is bad, and opens up the door to what can we do about that. The patient wants to know why there's a great deal of wear occurring in one particular area. Why did the tooth break? And more importantly for me, I want to make sure the implant is in occlusion. I mean, that when we do an implant-supported crown, I want to make sure that crown is in occlusion. Shim stock will allow us to do that. I find that shim stock I use how often?
Almost
everybody.
Yeah.
It's another part of the examination, which can take 30 seconds and gives one more piece of data, and it's another thing where the patient said, oh, I've never seen that done before. The TMD wedge we get from ACE Surgical. I want to know where the maximum mouth opening is. So essentially, as part of our initial examination, besides palpating TMJs and having the patient open and close, we have maximum mouth opening. And we use the TMD wedge, and we can see what the mouth opening is. It's good documentation from a medical legal standpoint. It also gives you a key as to whether the patient might have inherent TMJ problems and how difficult it might be to work with that patient. And the third thing is, it's another piece of data, and another piece of data that nobody else gets, but you can get that. The patient may want to know the significance of that, but more importantly, it's a very quick step, which again differentiates you as part of the examination while giving you another piece of data. Tongue depressors. You know, have you ever made a night guard and you put the night guard in, the patient says, I can't wear this. And then you're all frustrated. Well, you should be able to wear it. You know, night guards are supposed to relax your jaw. Well, my jaw isn't relaxed. You know, there's one way to determine whether a patient will be able to wear a night guard, and that's to take a tongue depressor. Here I'm using 3. I do it for different purposes, but take one tongue depressor and just hold this between your teeth for 30 seconds. And ask the patient how he or she feels. Patient feels better or neutral, then you've got a night guard candidate. If the patient said that hurts my jaw, then you haven't wasted your time and money, because you're going to have to give a refund in creating a night guard that the patient may not be able to use. So a stick can go a long way in helping you. Another thing is when a patient has a TMJ problem or has headaches or has pain lateral to the joint, or just let's say lateral to the angle of the mandible, is it always a TMJ problem? I know we're trained that TMJ problems have to do with musculature around the mandible, or from the skull to the mandible, and the 3 primary areas that we look at are the temporalis and perhaps the masseter, but certainly the external pterygoid and internal pterygoid, and we do palpate all of those. But what can we do to differentiate and see whether in fact that appliance is going to help? And one thing is to apply cervical traction. Now here's how I use it. I'll have the patient, patient may complain of some pain. And by the way, this happened today on an 83-year-old who had seen his physician. The physician said it was TMJ. And so I palpated, and I palpated the neck, and found there was some discomfort at the angle of the mandible near the C2, C3 area. And when I palpated right into the C2, C3 area, it hurt a little bit more. So the patient had a feeling of fullness or pain or some mild discomfort in that area. I did some mild cervical traction. So essentially you're placing your hand around the occiput and just pulling back gently, and you ask the patient, does that feel better? If it feels better, then TMJ therapy may not be the first thing to do. Maybe the first thing to do is refer to a chiropractor who can address the C2, C3 area. I happen to have a retired chiropractor in my reception room, a chiropractor that I used for most of my career, and he's well into his 80s now, and I called him in for a consultation. It was great because he had the opportunity to apply his trade, not that he did a chiropractic adjustment, but he did an examination on the patient and confirmed that it was a C2, C3 problem, and now we can help that patient without going through appliance therapy, only to find out that appliance therapy isn't going to work. The other way you can use this is for occlusion itself. You know, the mandible is it is the dependent variable, and it's dependent upon the musculature around it. Yet those muscles that are controlling the mandible are indirectly controlled by other parts of the body, particularly in the cervical area, and we could argue it goes all the way down the spine. Well, I have a patient tap his teeth or tap her teeth and then apply cervical traction. We're doing the cervical traction. We're not touching the mandible at all. And then I have the patient tap the teeth again. And we find out, and I ask the patient, does your bite change? And for some people it will. If that's the case, then we're going to get more bite stability if we get the entire system working well. If we get our head rotations good, whether we choose to use physical therapists or chiropractors, we could have arguments either way. We're getting the entire body working correctly before we do that final occlusal adjustment in the mouth. Can make it, and to me, from somebody who's studied TMJ for most of my career, that can make a big difference in overall stability and overall comfort, and know whether it's appropriate to adjust the bite first, or where maybe the problem is coming from someplace else, maybe from the cervical musculature, or from the vertebrae themselves. We're not saying thank you yet. You've got a whole bunch of other things you want to talk about.
Not really a whole bunch, but I did want to say one point on that you're big on that you didn't mention is communication. You gather all this data, you communicate it to the patient as to why you're doing it and what you're seeing and how it plays a role in their diagnosis and treatment planning. You also do a dictated letter to every dentist that's referring the patient over, so that the doctor understands what you're finding, and not only what you're finding, what you're recommending based upon your findings. So you do a lot of communication when you collect this data. And that way everybody understands why you're choosing the treatment plan that you're doing. Also, not only do you dictate that letter to the dentist, but you're also requesting a meeting, whether you meet face-to-face, or what you do, your number one way is the join.me. So you get them on the computer, on the phone, you pull up the CAT scan, you pull up these results, you pull up all this stuff so they can see everything and understand what it is you're doing. And I think it's a huge part of this is not only doing it, but communicating that to the patient and to the dentist so everybody's on the same page, understanding, and going forward.
Yeah, whether you're using Join.me or GoToMeeting, which are now owned by the same company. Yeah, online meetings with dentists and people you refer to are invaluable. And you know, we use this technology. You see us use it twice a month with GoToWebinar. This is still new technology to a lot of people.
Yeah, and the letters that he dictates, he has a dictation machine. He dictates everything in front of the patient. They can hear him dictating, and it comes up with a step-by-step. This is what I'm recommending. This is what I'm finding, and it gives steps on what's next, what to do. So that letter is sent to the dentist. That letter goes into the patient's chart so that we, the assistants in the office, know what's being scheduled, what's being done, because not only is he directing it by doing that, we have to take it over after he's done to call these dentists, make the appointments, make sure the patient comes back, and we have that as our guidance to do that.
Good. Did we talk about sequential treatment planning? Sequential treatment plan. Okay. So the final thing, we talked about it a little bit in last week's webinar, and that is sequential treatment planning. We want to dictate. And by the way, I find it important to have a dictating machine in front of me. Dictating in front of the patient, the sequence of steps that we talked about with the patient. Okay. Number 1, full mouth series. Number 2, periodontal root planing. Number 3, periodontal reevaluation. Number 4, please take a look at. Number 4, MOD. Number 5, DL. Number 6, looks like it needs a post-and crown. Whatever it is, and have that as a dictated note to the patient. Here's you dictating, and the patient and the dentist receives a copy of that. And then you and the dentist can work together on that sequential treatment plan. If you find the curve of SPIA is off, if you find that crowns are not in occlusion, or that there's some occlusal record that you've determined based on the shim-stock findings, you may actually be able to find some dentistry that's absolutely necessary that may not have been discovered by the general dentist. Of course, now it's important the general dentist actually appreciates what occlusion is and how we can really get the teeth together and get them meeting properly. But dictating that plan in front of the patient, we're using a traditional dictating machine. We use a digital dictating machine, plug it into the computer, and actually goes to my daughter who lives 90 miles away, and she types it out from there. I find to be a difference. So if we're looking at key differentiators, these are the key differentiators that we use in our practice. I'm sure you have your own as well, and please share them, and I'll share them with the group. Anything else we're going to do?
I think that's it.
All right, good. I hope all of you have great holidays. Happy Hanukkah, Merry Christmas, Happy New Year, and we'll see you on January 10th.
Happy holidays.